Thank you for joining me today. So my name is Jo Rumary, and I'm the National Continence Advisor for iMEDicare. And today I'm going to be talking about preventing harm and reducing risks in continence care, with a particular focus on catheter-associated urinary tract infections, or CAUTIs, and how alternative device choices can support safer care. A brief word about iMEDicare. So we are a medical device distributor working across the UK and Ireland in urology and continence management. And our focus is on bringing practical, clinically relevant products into patient care pathways, particularly where there is an opportunity to improve outcomes and to reduce avoidable harm. Now, before I begin this presentation, I'd like to tell you a story. So I hope you're all sitting comfortably, because you won't be in a minute. Thomas Bindley is 73. He's a retired electrician and a devoted family man. He was admitted to a stroke unit following a recent stroke that resulted in significant neurological impairment and urinary incontinence. Due to a severely retracted penis, a condom catheter, or sheath as they're more generally known in the UK, was not feasible. And pads were avoided, given an existing sacral pressure ulcer, so an indwelling urinary catheter was inserted. During admission, he developed a catheter-associated urinary tract infection, which progressed despite broad-spectrum antibiotics. His condition rapidly deteriorated into septicemia, and he died shortly after, leaving behind his wife of 50 years and 2 daughters. The hospital had refused the use of men's liberty acute, deeming it uneconomic. Are you all still sitting comfortably? I thought not. Now you can all breathe a sigh of relief, as it is a fictitious case. But I ask you, is it? So today, I'm looking specifically at why infection prevention is important. The aim is to show why urinary device choice matters, and where CAUTI risk sits in current practice, and how an external option can support better patient care, risk reduction, and more efficient use of NHS resources. So first, what do we mean by CAUTI? I did mention it before in the story, but I think it's worth a further explanation. A CAUTI is a urinary tract infection that occurs in a patient with an indwelling urinary catheter. The catheter bypasses the body's normal defences and creates a direct route for organisms to enter the bladder, the ladder to the bladder. The biggest risk factor is time. The longer the catheter stays in, the greater the risk. And that risk also rises when insertion or maintenance technique is poor, when biofilm builds up on the catheter, and this starts within minutes, or when the closed drainage system is broken, for example, changing a bag or using catheter maintenance solution. Clinically, patients may present with fever, discomfort, cloudy or malodorous urine, confusion, or more general signs of infection, especially if they're older or already unwell. So why does this matter so much in healthcare? Well, CAUTI is rarely an isolated event. It can lead to sepsis, like our poor Mr. Bindley, or pyelonephritis, prostatitis, and a whole heap of other nasty conditions, but also longer admissions and readmissions, particularly in vulnerable patients. There is also a major cost impact because these complications drive extra treatments, extra bed days, and sometimes escalation in care. And on top of that, CAUTI is a common trigger for antibiotic use, which contributes to antimicrobial resistance, which is a whole other topic. Regulators and healthcare systems also watch these infection rates closely. So poor performance can affect hospital funding, quality metrics, and reputation. And finally, every CORTI adds operational pressure for clinical teams, taking time and attention away from other aspects of patient care. So they really are a big deal. This leads us to the Men's Liberty solution, as briefly mentioned in Mr. Brindley's unfortunate story. It is an externally applied device designed for male urinary incontinence management. The key point here is that it offers urinary management without the same infection pathway created by an indwelling catheter. An important use of Men's Liberty is for gentlemen with adult-acquired buried penis. This can happen for a number of reasons, and this includes severe obesity, where excess tissues obscure the shaft, in lymphedema, where swelling surrounds the genital area, or in chronic erectile dysfunction with severe disuse atrophy. These patients can be particularly difficult to manage with conventional approaches. And for this purpose, I'll introduce you to Men's Liberty and Men's Liberty Acute, so with or without the bag, which can be used for all penile sizes and lengths. And these are available through established NHS procurement routes, including NHS supply chain and the drug tariff, which is important from an access and an implementation perspective. This slide illustrates the Men's Liberty. It is a fully external Glans adhesive product. This shows the practical side of the device. The process is straightforward, but good technique does matter. So the area is washed and dried, and then wiped again with the provided wipe and allowed to fully dry. This protects the skin. The device is positioned carefully following the retraction of the foreskin, so the opening aligns correctly with the meatus, and the seal is secured smoothly without wrinkles, and then the foreskin is then repositioned. Removal is designed to be gentle, using warm water or an adhesive remover rather than pulling. So the message here is that with basic training and familiarity, application is simple, consistent, and suitable for routine ward use. It's also worth noting that the penis does not need to be measured in order for this device to work, whereas the assessment for the traditional sheath is complex and time-consuming, and I know because I spent 5 years teaching it. And if it's done incorrectly, often leads to failure. Also, it's essential for correct sheath assessment to stock every size and style on the ward, which is costly and takes up a lot of storage. Men's Liberty fits all sizes, so only one box is necessary per ward. And please do take the opportunity to come and visit myself and my colleagues on our stand to see and handle this product yourself. So this is a piece of research from Kindred Chicago Central Hospital, and it was presented at the APIC conference in 2017. So in case you're not familiar with this, APIC is the Association for Professionals in Infection Control and Epidemiology. Now, I appreciate it's very small and very difficult to read. However, if you're interested, please drop me a line and I will share it with you. So it describes a nurse-led quality improvement project in a 107-bed long-term acute care ward. And it was aimed at reducing CORTI by replacing unnecessary Foley catheters with an external continence device where appropriate. The problem was that the traditional external condom catheters, sheaths, were unreliable and leaked. Now, this created extra work through repeated applications and linen changes. Where staff lost faith in these products, Foley catheters were often reinserted just to monitor input and output accurately. So to address this, they introduced the Men's Liberty external continence device and trained staff on when to use it, how to apply it properly, and how it fits within the wider CORTI prevention bundle. The results of this research showed that by switching to the men's Liberty, external device reliance on indwelling Foley catheters can be reduced. Also, supported research shows that this translated into measurable improvement over time. In that 16-month study, total urinary device days fell by 46%. Now, this may be particularly due to indwelling catheters tend to stay in longer, as once they're inserted, the days simply accumulate without reassessment. Foley utilisation dropped substantially, and the male CORTI rate fell to 0 after the intervention period. Now, I do think that's worth repeating. CORTI rate fell to 0 after the intervention period. The key here is that with the benefit, it was not just theoretical. With the right device choice, staff education, and a nurse-led prevention bundle, harm was reduced in real practice. I think it's also important to mention that during this research, nurses were empowered to challenge unnecessary Foley use. So to strengthen the economic case in the UK, an evaluation looking at the full pathway cost was developed with the York Health Economics Consortium, or YHEC. YHEC are a well-established health economics group linked to the University of York, with experience supporting the NHS and NICE decision-making. Now, these details matter because it gives the modelling a more rigorous and credible foundation, combining academic quality with practical relevance for procurement and service planning. And importantly, it's not a fixed model. You can input your own hospital data for your own use within this model. The underlying clinical problem is broader than CORTI alone. Urinary incontinence affects around 30% of patients on acute NHS wards, and between roughly 12 and 26% of inpatients are catheterised during their stay. Indwelling catheters increase the risk of CORTI, sepsis, and longer length of stay. For patients managed with pads instead, there are different risks, particularly incontinence-associated dermatitis and pressure ulcerization caused by potential prolonged moisture and skin exposure to urine. So from an integrated care system and procurement perspective, the issue is not just product cost, but the downstream cost and the harm associated with the care pathway that is chosen. So the decision problem was to evaluate men's Liberty acute across 3 adult male populations: the general population, vulnerable patients aged 60 and over, and the immunocompromised patients. The comparators were indwelling catheter use for the general and vulnerable groups, and pads with barrier cream for the vulnerable and immunocompromised groups. The model used a 30-day acute care horizon from an NHS and a PSS perspective. And just to clarify, PSS, Personal Social Services, is an umbrella term for community care, home carers, residential care, and social work involvement. The core value proposition was straightforward. It was to reduce infection risk, protect skin, lower adverse events, shorten length of stay, and ultimately reduce total cost despite a higher unit device price. So the model itself has 2 main pathways: the catheter comparator arm, where the key adverse event modelled was CORTI, and the pad pathway, where the focus shifted to dermatitis and pressure ulcer risk. Men's Liberty acute was evaluated across all relevant populations. In the base case, in healthy economic modelling, this is the main set of assumptions used for primary analysis. In this scenario, the researchers assumed that the external device does not drive CORTI, dermatitis, or pressure ulcers. This is based on its non-invasive mechanism and early clinical evidence. They then carried out scenario analysis, varying key assumptions, such as staff time and pre-existing skin damage to test how robust the results were under real-world conditions. The key clinical inputs. This is the data fed into the model. This reflects the risks in each pathway. For indwelling catheters, CORTI prevalence was modelled at 3.8% in the general population and 4.7% in the vulnerable patients, with coated catheter performance also considered. In the PAD pathway, dermatitis prevalence was 4.3% in the general population, with higher relative risks in the vulnerable and immunocompromised groups. Pressure ulcer prevalence was also materially higher in those high-risk populations. Mortality was linked to CORTI and pressure ulcers, while dermatitis was not modelled as having a direct mortality effect. Altogether, these inputs capture how risk escalates in the patients that we not only worry about most, but also drive the highest cost and workload. On the cost side, Men's Liberty is priced at £8.78 per unit, with higher use in the first 2 days and lower use thereafter. Now, this is generally due to familiarity and men having unique anatomy. Pad costs and barrier creams were also included, along with adverse event costs, such as roughly £620 for CORTI and around £7,000 for pressure ulcer, and a bed day cost of £536. So these are the real costs, and these are the ones that impact NHS budgets, bed capacity, and quality metrics. Baseline length of stay was set at 8.3 days, with additional time added for adverse events. Operationally, the model also recognises potential workforce benefits. Application takes only a few minutes. It doesn't require a registered nurse. There are fewer pad changes, and reduced complications can support patient flow through to discharge. This improves hospital capacity and staff efficiency by freeing up beds and reducing clinical workload. The bed case results are encouraging. In general population, Men's Liberty was associated with a saving of around £20 per patient and around 38 fewer CORTIs, about 1 fewer death per 1,000 patients treated, and a small reduction in length of stay. In vulnerable patients, the effect was stronger, with savings of around £39 per person, around 47 fewer CORTIs, and a similar mortality reduction per 1,000. More broadly, in higher risk groups, the modelling suggested substantial system savings driven by fewer adverse events and shorter admissions. So although the device has a direct acquisition cost, the downstream savings more than offset that off in the base case. Sensitivity analysis. Now, this tests how much the models change when key assumptions in the model are varied. So in simple terms, it shows how robust the findings are. The most influential variable was the assumed CORTI risk associated with Men's Liberty Acute itself. In very low CORTI settings, the savings versus indwelling catheters may narrow. However, the PAD comparator pathway remained very robust, and no parameter variation reversed the cost savings results there. So overall, the analysis suggested the conclusions are mainly driven by adverse event incidents and the cost of treating those events, rather than the small changes in the product price alone. We've also tested the model under different assumptions, and the results are robust across most realistic scenarios, so it's not dependent on one set of perfect inputs. So what does this mean in practice? Well, clinically, using an external option where appropriate can reduce CORTI risk by avoiding unnecessary indwelling catheter use. It may also reduce moisture-related skin damage associated with pad use. There are likely benefits in terms of patient comfort and dignity, although those were not fully captured in the model. So a unit cost basis, it is more expensive than a catheter or pads. But when you look at the full pathway, it reduces complications and length of stay, and that's where the model shows overall cost savings. So the take-home message from this is that with YHEC, we have developed a robust full pathway model that reveals the hidden costs of complications and extended stays. Now, using your own data, you can clearly see whether reducing avoidable harm delivers value in your hospital. In other words, we found that the way continence products are typically evaluated on unit cost doesn't reflect what actually drives cost in hospital wards. So the sensible next steps is not to rely on our assumptions, but to test this in your own environment. Now, this can include staff training and implementation support, which iMEDicare can provide anywhere in the UK, alongside collecting local real-world data on adverse events, staff time, and outcomes. We'd recommend a pilot in acute wards, starting with high-risk cohorts as a practical way to validate impact locally and support procurement decisions. This will give you a clear evidence-based case for whether this delivers value in your own setting. So thank you very much for listening. I hope this has shown that safer continence management is not only a patient safety issue, but also a meaningful clinical and economic opportunity.